Hello, my name is Dr. Colin Birch. I'm very privileged to be the head of obstetrics and gynecology for the AHS in the Calgary Health Zone. I think women's health is so important. Women make up half the population, and a specialty that's devoted to women's care really needs to be highlighted on a greater level than it is currently. Now is really to speak out about the importance of their health and also to educate themselves about their health and use that opportunity not only to educate themselves but to educate those around them and speak out about how important it is. You know, the woman is a cornerstone of each family and so needs to be well, and the only way they're going to be that way is by keeping interested in their own health.
Hello and welcome to Calgary Health Foundation's Women's Health Series. I'm Jody Hughes from Global Calgary, and I am so glad that you've joined me for this very important conversation about perimenopause and menopause. As Dr. Birch mentioned in the opening video, women make up more than 51% of the population, yet we don't hear enough about women's health. In fact, women's health research receives about 2% of the total research investments from the Canadian Institute of Health Research. And as you know, as women, we often put our own health on the back burner to our family and our loved ones until something happens. And we're hoping to change that tonight. We believe that education is empowerment. Calgary Health Foundation is a nonprofit that works with hospitals, community health programs, and long-term care in Calgary. With the support of donors, they invest in breakthrough initiatives and projects that are challenging and changing the status quo. We do have some of the best researchers and clinicians in women's health right here in Calgary. Now, just a couple of housekeeping items before we get started. There is a Q&A button at the bottom of your screen. This session is all about you getting the information that you need. So please use that button. And just so you know, if you choose to use the chat, your questions will be public. We are going to get through as many questions as possible. This will be recorded and then made available later as well. It is a true privilege to first welcome Sandra Baker for our traditional land acknowledgement.
Hello, my name is Sandra Baker, and I am an educator with the Indigenous Wellness Corps. My grandmothers were Mi'kmaq and Acadian. I am a proud Métis woman. I was asked today to deliver this land acknowledgement for you, and I'm very happy to do so. When the blood in your veins returns to the sea, and the earth in your bones returns to the ground, perhaps then you will remember that this land does not belong to you, but it is you who belong to this land. I would like to take this opportunity to acknowledge the land in which today's speakers are delivering from, and myself as well. This is the traditional territories of the people of Treaty 7 region in southern Alberta. This includes the Blackfoot Confederacy, comprising of the Siksika, the Pekainai and Kainai First Nations, the Tsuut'ina First Nations, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wellesley First Nations. The city of Calgary is also home to the Métis Nation Region 3. A land acknowledgement is a formal statement that recognizes and respects Indigenous peoples as traditional stewards of this land and the enduring relationships that exist between Indigenous peoples and their traditional territories. Thank you. Merci. Welalen.
Well, thank you so much, Sandra. There are so many women joining us tonight, and probably some men too, you lucky guys, as we dive into this conversation around perimenopause and menopause. I am so very excited to welcome Dr. Fiona Mattatall to this important conversation. She is a born and bred Calgarian who went out east for medical school and specialty training in obstetrics and gynecology. When Dr. Matatal returned to Calgary, she joined the women's health team at Rocky View General Hospital, and today she is also an assistant professor at the University of Calgary and lectures at the Cummings School of Medicine, helping to shape our future OBGYNs. We are very lucky to have her, and if you would like, you are welcome to follow her on Twitter at Fiona Mattatall. You will quickly see that she is a wealth of knowledge and has a very good sense of humor. So thank you so much for being with us today, Dr. Matatal. Would you like me to call you Dr. Fiona? What's best for you?
I think Fiona is just the easiest, and thank you for having me tonight.
No problem. We have so many questions, so many people watching, so I want to get through some of the very basics. Asking for a friend, I'm 47 years old. What exactly is perimenopause and menopause? We're hoping to maybe put some definitions around this, because I feel like as a woman, when you grow up, you learn so much in school about, puberty, what's going to happen to you. And then it's sort of like the rest of your women's health just gets forgotten until all of a sudden you're just like that amazing video that we watched in the beginning. So what is perimenopause and menopause?
Great questions. And you're right, we get a lot of education as we're going through primary school, with regard to puberty and what's happening and what's changing in our bodies. And then we hear nothing as we're going through perimenopause and menopause. And I see a lot of women in my practice with a lot of questions around all of this. So I think to explain it best and to empower everybody listening with some knowledge, I'm going to go back to some of the lessons you probably learned in grade 5 to 6 sex ed or in grade 12 biology. So John, could you show us that first slide? So this is a schematic of what's going on in our bodies in a monthly cycle for someone who is before the age of menopause. It looks pretty tricky, but we're going to break it down. The bottom lines are hormones that are produced out of our brain called LH and FSH. And sometimes these are hormones that you may have checked with blood work throughout your reproductive life. Our brain actually tells our body what to do. And the brain tells the ovaries directly, and that's the next two lines. The yellow line is estrogen, which I think a lot of people have heard of as one of the main female hormones produced by the ovaries. And the green line is progesterone, which is the secondary hormone that the ovaries make. So in a cycle, the ovaries are producing these two hormones at varying levels to help induce ovulation, which is the next line down. That's a little ovary and a follicle coming out. And it also causes the lining of the uterus to get thick in anticipation of a pregnancy. John, can we go to the next slide? And so what happens in a usual menstrual cycle for someone, say, between the ages of 20 and 40, is you can see this cycle repeats over and over. And I've just shown the estrogen and progesterone, and it's a beautiful symphony of hormones going up and down and up and down. And that would result in a very regular menstrual cycle. If we go to the next slide, perimenopause are those years leading up to that final period. And what happens is you could have two cycles that are very regular, like we would have seen before, but then the ovaries stop making hormones for a stretch of time, and that could be a time when a woman doesn't have a period. And then the ovaries go a little bit on a roller coaster ride, and you can see the estrogen levels start to get higher and higher, and the progesterone levels aren't doing that same sort of pattern from before. And this hormonal change and shift is why we see a lot of the symptoms that we do in those years leading up to that last period. And then comes graduation. If we look at the next slide, and when you graduate to menopause, and I do view it as a new phase of life and a graduation, rather than something that we have traditionally thought of as negative and the end of something, I actually think of it as freedom from things like periods and freedom from cyclical symptoms and freedom from needing to worry about birth control. And the ovaries really slow down making hormones, and you can see the estrogen and progesterone levels are now both very constant and on the low side. And sometimes we get symptoms because of that low level of those hormones. And I'm sure we'll get into talking about some of those symptoms.
Well, I'm glad that you brought that up, because, if you look up menopause or perimenopause online, it's like the coconut oil or the CBD oil of any sort of a health situation, because it can make you have longer periods, shorter periods, no periods, too many periods. You can be sweating, you could be cold. It's everything. And yet it's not, you don't see a lot of the positive symptoms in there. It's not making you smarter. It's not making you skinnier or taller. So, what are common symptoms? Do the vast majority of people go through the same symptoms, and do they deal with it for the same amount of time? I know it can last a long time. but do most women have, is there a majority that go through the same sort of things?
So what we see is, yes, all of that. And every woman's journey through perimenopause and menopause is unique to her. It might be similar to what, say, her mom or older sister or aunts in her family did. It could be a similar journey, but it may not be as well. It can, the last menstrual period on average in Canada is around age 51, but that's an average. For some women that can be quite early, and for some even into their late 30s, and for some women it can be later. And I've seen a few patients who've had their last period into their 60s. So it's quite a range. In terms of perimenopause, which are those years leading up to it where you might see irregular cycles or some other hormonal changes, that can last up to 10 years. Just like the video said, it can be up to a decade of symptoms. And then those can last past menopause for an average of 8 years, but it's an average. Some women have very few symptoms and they wouldn't, complain of anything. And I think many of us are quite jealous for those women. And then some can last more than a decade.
Okay, well, aside from those unicorns, they probably also had the babies that slept through the night right away. It's not just an old lady thing, is it? So when does it start? When should we start to think, is this menopause? Am I just tired? Am I sick of Zoom calls? Like, when do you know that maybe this is menopause or perimenopause?
Right, and these are big challenges because a lot of these symptoms can overlap with other health conditions. So like we saw in the video, a woman didn't see her doctor, who I recognized as Mr. Kim from Kim's Convenience, who was not the most helpful of physicians. And I would hope that a family physician or nurse practitioner would be much more supportive and helpful. But sometimes there are conditions and symptoms that would be good to review with your doctor to see, could this be something common like thyroid dysfunction? Could it be some mental health issues? There's so many things that can overlap with menopause and perimenopause symptoms. It can be helpful to check in with your primary health provider. Comparing notes with women in your family or friends can also be helpful to see, is this normal? Is it not? But certainly there are some warning signs of some health conditions that would require more attention. And one example, a very common thing that I see, are periods that start to get very frequent or very heavy. And those can be a normal part of perimenopause, but can result in some health issues like anemia from lack of blood loss.
Okay, we saw that doctor who, as you pointed out, wasn't exactly helpful. It feels like we're in a bit more of an era where we as women know to, take control of our own health and feel empowered and ask questions and not just have to deal with it anymore. We don't just glow, we sweat. Like, we can be a little more honest about things, about what happens to us as women. But how do you make sure that you're covering all of your symptoms? What's the best way to approach a practitioner? Do you just unload this huge list of possible symptoms? Because you don't want them to think that you're, not right in the head either, because you're a hypochondriac and you're thinking that everything is perimenopause.
Right. One thing that I find is really helpful is charting it. So you could even do that on a simple paper calendar and just chart, okay, what days am I bleeding? Are there days in the month that I'm having significant problems with, say, sleep or mood or bloating? There's apps that can track that. You can put it into your calendar on your smartphone, and having an organized look at what's happening through a month or a couple of months can be helpful when a physician like me is looking to see, is there a pattern to this?
We hear a lot about hormone therapies. I feel like I heard that they weren't as, vogue as they once were. Are they still being used? If so, is it like birth control? Are there many different types that you could choose from, or is it just sort of a one size fits all for hormone therapy?
So it is definitely not a one size fits all. It is quite individualized. And hormone therapy has a very interesting backstory that goes back to the 1940s. And we came through, a lot of us will probably remember our mother's generation or our grandmother's generation, where women, almost all women were placed on hormone therapy and stayed on until they died. Then there was a large study that came out in the early 2000s that showed some concerns with some types of hormone therapy. So that made a lot of physicians pause and say, maybe this isn't for everybody. And that was about 20 years ago. Since that time, the prescribing of hormone therapy and decisions to go on hormone therapy, how long you stay on, is quite nuanced. And so there are many different types of hormones that women can be on depending on their own personal history and their family history. And the choice of which one to go on and for how long is something that you need the help of someone who's experienced with prescribing hormone therapy to go through. And in somewhere like Calgary, we're very lucky. We have a number of good practitioners in the city who can help with those discussions. Many family physicians are able to do that, but if not, we do have specialty clinics and special practitioners who are able to go through that discussion with a patient.
Are there risks and benefits to going on hormone therapy? I mean, I know women who've gone on it. They love it. They say it's life altering. They feel much happier. Just it gives you a little bit of control back, it feels like. But what are the risks and what are the benefits that we need to consider?
So there are, like any medication, there are, of course, risks and benefits. It's hard to say what they are for the whole class of medications because we have about 4 different types of progesterones that we can prescribe. We have 3 or 4 different kinds of estrogen compounds that can be prescribed. So it's very different depending on what patients are looking for. The bottom line is we prescribe hormone therapy for women who are having symptoms of perimenopause or menopause, most commonly hot flushes or sleep disturbance, but sometimes some of the mood issues. We sometimes use hormones to help with some of the symptoms in perimenopause, like heavy periods. So that would be an individual discussion. The points that I like to discuss with women who are considering starting on hormone therapy are specifically how would they benefit them and does it look like it would help their symptoms. I do like to touch on the impact on the most important long-term health outcome for women, which is heart health. And I think we all worry more about things like breast cancer, ovarian cancer, but the reality is the majority of women will suffer from cardiovascular disease, not cancer. So I do have that conversation about cardiovascular health and how hormones will impact that. We do talk about cancer risk, and it's very different depending on which hormones you're looking at. We talk about bone health as well, because as we age as women, we need to pay close attention to our bones because keeping our bones strong will give us the longest, best life.
I'm glad that you brought some of those up because you also hear about menopause and the link to cancer. Is that real? Why would it happen? And it seems to be specifically that you hear a lot about it with breast cancer.
It's true. And there are some forms of hormone therapy combined together that do show an increased risk of breast cancer after 5 years of use, but it's not all forms of hormone therapy. And so I think that's an important thing for women to know is that not all hormones are going to be linked to risk of breast cancer. And in fact, we have some newer hormone combinations that will reduce risk of breast cancer. So I think it's, again, a good conversation to have with whoever is prescribing that hormone therapy to consider.
Is it just from hormones, or does it also happen sometimes just as a part of menopause, or is that just one of those things that you're aging and you might likely be more at risk for things like heart disease and breast cancer, and so maybe it gets lumped in thinking that it's from menopause itself?
Mm-hmm. Great question. And, things like heart disease and cancer, unfortunately, increase with age. And that's true for both men and women. What has a larger impact than hormone therapy on cancer rates and on cardiovascular health is things that are very simple and our grandmas would have told us. It's diet. It's eating a well-balanced diet that is low in processed foods. It's getting out and exercising. And whether that's going for a walk or rollerblading or going dancing on a Friday night when we can go back to those types of activities, not smoking, those are all much bigger factors in overall health. And that is one thing that I think is really great about this time of life, and I'm at this time of life as well, is as things are changing, it is a good time to check in with yourself and check in with your primary care provider and look at some of those lifestyle things and think, okay, as I'm going through this change from my reproductive life to when I've graduated and I don't need to worry about that as much, can I be making some of those healthy changes to improve my quality of life as I go forward? And as I said, our diet, our exercise, our habits will have a huge impact on our long-term health. And it's never too late to make improvements in those things.
When you are pregnant when you're a teenager, it seems like we're often just exhausted. Does menopause have any sort of an impact? Do the hormones tied to perimenopause and menopause have anything to do with fatigue? Is that a common symptom that people will experience?
Fatigue definitely can be a common symptom in perimenopause and menopause. There's a lot of overlap. So if a woman is having very frequent or heavy periods in her perimenopause, she could be anemic. And so she could have fatigue because her iron levels are low. So that would be important to look at ways to reduce the volume of blood that she's losing. And we have many different treatment options for that. She could also look at supplementing iron. So before you blame it on perimenopause, there could be something else going on. And then as she's going from perimenopause into menopause, a big factor with fatigue is sleep. And sleep interruption can lead to a whole host of issues, including fatigue. So looking at good sleep hygiene, which is tough to do, and I am not the best at it. I'm good at telling people and suggesting what they should do to improve their sleep. But I am on Twitter at 10 o'clock at night, and I know I shouldn't be, or watching a TV show, and I should be listening to relaxing music or putting on a Calm app. But sleep hygiene can be really important in menopause. So it might be hormonal, but maybe it's habits too.
What is the number one question you get when women walk into your office with regards to this?
That's a great question. I get some pretty interesting questions in an office that focuses on reproductive and sexual health. I think one of the more common questions I get is, what can I do to feel better and get my life back on track? And I think, what I see, and it's not for not everybody, but especially, us women in our 40s and 50s, if we have chosen to have children, we're often at that stage where the children are quite independent, maybe leaving home. And so that part of our life is gone, and now you can focus back on yourself. But then we might be also looking at parents or family members who are older, and we're sort of sandwiched between those two. And it's just how to get my life back and live my best life.
I can understand that. I've heard of that. So when we are planning for our visit, when we have our conversations about perimenopause and menopause, is a family doctor enough? Are they equipped to be able to answer your questions, or do you think that women should be going to see somebody, every woman should be going to see somebody who specializes in this?
I think many family physicians are fantastic at helping women navigate through this time. However, not every family physician may have had exposure in their training to how to navigate some of these problems, but they should be able to refer to someone who can navigate. And if you're a patient and you're feeling dismissed like the woman was in the video, you can ask for a referral to someone, either a family physician who has a special interest in women's health, and we have many of those in Calgary. We're very fortunate. Also can be referred to a specialist obstetrician gynecologist like myself, and we have gynecologists in all 4 quadrants of the city, all over Alberta. It takes a little bit longer to get in to see us because we are managing sometimes some of the more acute issues in women's health. But one thing I feel is you can also do on your own is to find good information and educate yourself. And I'm hoping tonight's session is a good springboard for people to learn more about their bodies. I think in the last few weeks, we're hearing a lot of discussions about menopause in the media, which is great. And it's because of a book that was published 2 weeks ago. And I'm going to show it. I hope that's okay. It's not my book.
Yeah, my friends have all brought this up already.
Yeah, so the Menopause Manifesto is a book that came out 2 weeks ago by a gynecologist who, her name is Dr. Jen Gunter. She's a Canadian who works out of the US, and she has put together a masterpiece of a book. It goes through in more detail what we talked about at the beginning about, explaining what hormones are, what the changes are. She goes through history and some of the misogyny behind messaging about midlife women, which is a very interesting read, but also goes through some of the symptoms, warning signs, and I find helping to bring your knowledge base up to a level where it is for a gynecologist like me is really empowering. And this is not hard information. I think almost every woman could understand this and arm herself with information and start to understand what's going on in her own body.
I'm so glad you brought that up about the misogyny and the perceptions that we have, because it does still very much feel like, among the people that I know at least, that they're not totally comfortable, calling it out as maybe they are perimenopausal or menopausal, because there is a stigma. So how do you think we can get around that? How do we fight for ourselves? But, you don't want to be weak. You don't want to be judged. It feels like it's a very precarious position when you're already not feeling great and maybe you aren't very happy that day.
Right. And, I think the more we are honest about our life experiences with each other and not making it look like a perfect Instagram moment, and talk about the honesty. And, if I'm at work, I'm fortunate because I'm surrounded by a lot of women of similar age, and I'm having a hot flash. I'm not going to try and hide it. I share that with friends. We're very honest about, yep, I'm not doing great. I had a terrible night's sleep because the hot flashes kept me up. I think the more we discuss honestly about what's happening to ourselves, it normalizes it for other women around us, and then we can have really honest conversations. And one thing I've seen in women's health over the years is that many women suffer in silence and think it's only them. And I think a lot of the talks in this series have been great. Like I was watching the one with Dr. Kim Fine discussing conversations about urinary incontinence. And the last generation of women would have never discussed that with each other. But I think the more we talk about that, the better it is for everybody.
My dog Phoebe is giving her bark of approval in the background, so I apologize for that. What about libido? Can we touch on libido? Because you do hear about that being affected, and at a time when you're already looking in the mirror and all these Zoom calls and thinking like, where did these wrinkles come from? That can't help with how your overall mental well-being is.
Libido is complicated, and I think every woman knows that personally and appreciates that. there's so much interesting research into the sexual response of women. And what has come out of the last several decades of research is that it is much more it's much more complicated than the Masters and Johnson method that was worked on way back in, I think, in the 1950s. The sexual response in women depends on so many things being in place. You need to have had good rest. Hormones play a small piece of that. Your relationship, your attraction to your partner, your worries about everything else going on in your life. And so everything needs to be in a very perfect state before your libido is going to be at its best. So there are many reasons in perimenopause and menopause where libido can be affected. I think it's an oversimplification to think that hormones are a single fix for this. And when I have patients come into the clinic who are having issues with libido, we look to see, are there any things in that circle that we can help with? Is there pain with sexual touch or sexual intercourse? And sometimes there's something there that can be fixed. We can touch on hormones and see where we are there, but I will start to ask about relationship issues. And I will often refer on to either a psychologist or a therapist with specialization in sexual health. We have in Calgary an amazing family physician who specializes in sexual dysfunction in men and women and couples. And so I will sometimes refer patients on to her for what are often long conversations and diving into some areas that you might be surprised are actually affecting sexuality. So it's usually not an easy fix with a prescription like for Viagra. It's not that simple.
Okay, I'm going to ask one which might be a simple question. It'll be our final one before we open up for the Q&A. Is it true that however your mother went through this, you will have the same experience?
It's not exactly true, but there might be some similarities. So you probably will have more in common with your mom's experience than you would with someone who's not related to you, but it's not always going to be the same.
All right. Well, Dr. Matatal, Fiona, thank you so much. I know we have so many questions, and so we will open up the floor now to our questions. I believe Val will be helping with that.
Thanks, Jody. Yeah, tons of great questions. I'm hoping we can get to as many as possible. But Fiona, I know you brought some, I guess, just common things that might be beneficial for women to wanted to maybe show them just so that, people can normalize. I think you have a variety of hormone pieces.
I do. Yes, I was in the office today and I filled my bag with hormones coming home from the clinic. So in terms of hormones used for, let's just focus on menopause itself. For menopause symptoms that are systemic, so that might be hot flushes as our main one, but sometimes joint pain or fatigue or sleep issues. Women would take systemic hormones. So that means either a pill, and these are example of some of the progesterone tablets that we would use. So it could be an oral medication, but there's also ways to take hormones through your skin. And I just want to show you a couple. So these are patches that have hormones, and you can see they're not big. So these are tiny little patches that you would change, put on your skin twice a week. So this is a very tiny one. It's a very low dose estrogen. And then this is a larger one, which is a little bit higher dose estrogen. There's also estrogen that can be done transdermally. This is a cute little package that it comes in. Isn't that so nice? Looks like a little purse. And these are little packets of gel. I'm just going to open it up here so you can see. And this is gel that you would squeeze out. It's just a tiny amount here. I don't know if you can even see it. It's a little bit of gel, and then that just gets rubbed on your skin, like on your arm or your leg or your belly. And then the hormones would go in that way. So those are examples of systemic hormone therapy that's used for systemic treatment. But we also have a very specialized need for vaginal estrogen. So in women who have vaginal dryness, those systemic hormones may not help with those symptoms. And so there are vaginal estrogen solutions for that. And so there's a tablet form, and it comes in a little tube. And I'll try and, whoo, I shot it across the room. So never mind. But then we also have some creams, and these come in a little tube. And then the cream then goes into a little inserter, kind of like a tampon inserter, and that estrogen could be then placed into the vagina. But we also have non-hormonal options for vaginal dryness, and those are little suppositories. And these are little vaginal moisturizers, so they're little ovule that gets placed in the vagina. You can put them in every day to help with some of those just more local symptoms in menopause. So that's my
great.
show and tell.
That's awesome. No, I think it's important that people see options and know exactly what we're talking about when we're talking about hormone therapy. Some of the questions actually are to do with hormone therapy, and particularly some of the symptoms that you talked about, bone and joint health, etc. So if we're going into perimenopause and we're still late 30s, maybe early 40s, do we consider talking to our doctor about hormone therapy right away, or is that something that maybe should be down the road as we start to experience more menopausal symptoms?
Those are great questions. So in terms of if you're considering starting a hormone therapy, it would be appropriate to start it in perimenopausal transition, or once that last period has happened, up to 5 years after that point. If a woman has gone more than 5 years past her last period, there are some additional risks to starting on hormone therapy, and we might look at non-hormonal options at that point. So usually it would be sort of either in menopausal transition or very early on afterwards that we would look at hormones.
Yeah, and the period question is a good one, because there's been a lot of questions here, really for people that either had a hysterectomy or are taking birth control that might actually have stopped their period a course of time. Can you talk a little bit about how, I guess, they might know they're going into perimenopause and what they should be looking for? And is it safe to even continue on your birth control at that point?
Oh, such good questions. And I get these a lot in the office. So for women who've had their periods stop because of treatment, specifically to stop your period, like a hysterectomy or endometrial ablation or a birth control pill or a progesterone IUD, it is really tricky to know when you are in menopause, because you don't have a period to tell you, I've stopped, I'm moving on. And so for those women, we go on symptoms. And if a woman is having, say, hot flashes and she's 48 years old and she's had a hysterectomy, what we would do is treat the hot flashes. Hormone levels, so having your hormones tested going through perimenopausal transition is really tricky, and it's not straightforward. I have lots of women who ask me if I can have my hormone levels checked, but through menopausal transition, if you remember those graphs we looked at, the hormones can be up and down, and so you can have what looks like a menopausal hormone level, and then the next month your ovaries decide to kick in. So it's really tricky and not helpful to measure hormone levels as you're going through menopausal transition. So we would go more on symptoms. And so let's say another woman is 48 years old, had a hysterectomy, so we don't know if she's in menopause, but she's feeling great. She wouldn't necessarily need any treatment. She should just keep living her best healthy life.
That's amazing. I think a lot of women kind of struggle, like we've talked a lot about what's normal, what's not normal. And for women that are starting to feel like, this is not me, my mood is changing, I feel like I'm really starting to maybe get mood swings, or maybe they're feeling like they get hot flashes. Is there any early interventions that they might consider? We talked a lot about lifestyle change, but anything that they should really be thinking about, or herbal supplements or any natural remedies that they can start to introduce to reduce some of those symptoms?
So herbal and natural remedies are a little bit tricky to navigate. Some of the challenges are we don't have as great quality data on those supplements and natural products as we do on pharmaceuticals. There just hasn't been the money and work put into them. Many have the same effect as placebo. And placebo is when you are taking something that doesn't contain that product, but you do see improvement. So on one hand, you could feel, well, I'm taking a supplement for menopause and I'm feeling better. If it's the placebo effect, is there any harm in that? Probably not, other than the money that you're paying for the supplement, as long as what's in that supplement is safe. One of the concerns we have in Western medicine is the quality control of some of these supplements. And there's been many studies looking at different supplements showing that what is on the label is about a quarter of the time not actually in the product, and there could be contaminants. So I would say if someone is wanting to look at using supplements or natural products, better than going to the health food store and picking those up is get some guidance through someone who understands those products and can point you in the direction of ones that have good active ingredients. So that would be considering working with someone like a naturopath who would be able to navigate you through that world, because it is an interesting world. And when you go to a health food store, you can see product after product with claims that may or may not be based in evidence.
Yeah, that's great. And I wanted to also ask a little bit, I guess, not really about some of the natural remedies, but maybe some things we shouldn't necessarily do, which, some questions about concerns, about how much alcohol we're consuming, or some habits that might actually be elevating our symptoms early on too.
Mm-hmm. Again, these are really good questions. So things to avoid. Smoking is number 1, 2, and 3. Not only for hot flashes, but for overall health. But smokers do report more hot flashes. Other things to avoid would be triggers of those hot flashes. So sometimes that are hot beverages. Caffeine can be a trigger, but often a very necessary part of our life. And alcohol specifically, you mentioned. And interestingly, the data shows that light alcohol consumption is associated with a slightly lower rates of hot flashes or menopausal symptoms. And by light, I mean less than 1 drink a day. Women who have higher alcohol consumption, so in 2 or more units of alcohol a day, and a unit would be a small glass of wine, not like a venti size gin and tonic. So a small amount of alcohol intake is fine for as long as you don't have issues with alcohol or addictions in your background, your personal history. But getting into higher than 2 drinks a day would be worse, not only for hot flushes and menopause symptoms, but worse for your overall health in terms of cancer risk. And just in case people think about these things this way, you can't take all of your 7 drinks a day and drink them all on Friday night. That actually will not help.
Yeah, 1 glass a day, depending on the size of the glass.
Yeah,
I heard that. I wanted to go back a little bit to abnormal bleeding because we have had so many questions about this. I want to make sure we're addressing as many people's questions as we can. So some people are asking, after I've gone through menopause, still having some bleeding, or while I'm going through menopause, having a lot of bleeding. So can you talk a little bit about, I guess, when we consider it normal, when we should seek our family physician, and then maybe when we really should be pushing for that referral to a specialist.
Okay. Yeah. This is probably the most common thing I see in my gynecology practice is periods gone bad. Anytime you are filling a pad or a tampon in an hour, that is a problem. That is abnormal, and you should be seeking medical care. If you're noticing a big change in your periods where they're becoming less than 3 weeks apart, or you are starting to bleed more than 7 days, or you're filling more than, I'd say, 7 or 8 pads or tampons a day, that's something that you should be seeing a physician about. And your family physician would be a good starting point. That would be in perimenopause. After your last period, you should not be bleeding. So any bleeding that happens once you've been more than a year out from that last period, you should be seeing your family doctor about. The reason these are really important is that we want to make sure women aren't just pushing this to the side and saying it's normal, it's fine, because there could be something underlying that bleeding that could lead to major health problems. So that could be thyroid problems, but more worrisome, cancer of the uterus presents itself as abnormal bleeding patterns for women, whether that's in menopausal transition or after. There is a very straightforward test to rule out cancer of the uterus, and it's a cancer that if it's caught early, which most cases are, we can often treat it and cure it. There's not too many cancers there are cures for, but if we catch this one early, we can save a life. So if you are experiencing very heavy bleeding, leading through that menopausal transition, or any bleeding after menopause, come see a doctor. Sometimes there is a very easy fix once we've ruled out cancer. And like I said earlier, through menopausal transition, if a woman is having very heavy bleeding, we have a number of different treatment options that can help reduce that risk of anemia and give you your life back. I've met so many women over the years whose lives are ruined by their periods. They plan family trips around their periods because they don't want to be outside of the home so they can be close to the washroom because they have to change a tampon too frequently. So your period should not rule your life. It should be the other way around.
I love that message. I think that it's like we should be able to live our life. And I think some of the other questions people had on symptoms, it might be the same answer, but Jody talked about some of the long list that women get to experience. But some specific questions have come in from varying urine odor to a lot of joint pain questions, particularly hips, breast pain, sensitivity. Are all these just as we should expect them? And, you know, when should we start to think like, I can't live like this anymore. I need to do something about this.
And again, I think if your life is revolving around these symptoms, there's a problem and you should get them looked at. Did you want me to go through those different symptoms and talk about them?
I think so. There's a lot of questions about various. So I think if you can cover a good chunk of what to expect, that would be great.
Okay. Joint pain is very common going through menopausal transition, but it can overlap with symptoms of arthritis, which is not a hormonal problem, it's a joint problem. So with joint pain, that would be a good reason to check in with your family physician and look to see, rule out things like rheumatoid arthritis, osteoarthritis. The treatments for those are very different, but we do know that women who are on hormonal therapy through menopause do have less joint pain. So for some women, hormones can help with joint pain. One of the other symptoms was, someone mentioned, was a change in urine odor. Urine odor can change based on a lot of things, and I think any of us who eat asparagus know that's true. So what you're eating in your food or any medications or supplements you're taking can change the odor of urine, how concentrated the urine is. So if it's more concentrated and you're not taking in as much fluid, you might notice that stronger. But hormonally, there can also be changes in urine smell as women go through their stages of life as well. Can you remind me what the other symptoms were?
Nipple sensitivity and overall breast pain.
Right.
A lot of questions about bloating, constipation, things like that as well.
All right. This is like head to toe symptoms, which is a lot of what it's just like the video. Could it be perimenopause? Yeah, it could. So in terms of breast, anytime that there's a change in breast, if there is a worry about could there be some a mass or something that's felt, that is something that you should get in to see your family physician about. If there's a change in sensitivity or in terms of fullness or a feeling of even just sort of bloating within the breasts, that is often hormonal. As women are going through perimenopause, it's quite common to have those symptoms sort of wax and wane as your cycle goes on. But if you notice that you were having pain that was not going away, that would be reason to get in and have your physician do an exam on breasts. Similarly, bloating, especially in the abdomen, can be something that is associated with hormonal fluctuations. But again, I would expect it to get better and worse throughout a cycle. If bloating was staying around and not going away, I would be wondering if there might be something else going on. So that would be, again, reason to come in and get checked out. What might be helpful is something that Jody and I talked about at the beginning, which was taking a calendar and writing down your symptoms and seeing, is there a cyclical pattern to it? Or is this something that is there all the time? And that would be really helpful for your physician to try and understand what could be behind that symptom.
Yeah, and would memory fog, brain fog or memory loss, things like that also be very much the same, trying to write when you're feeling fuzzy and...
Right, and you know, in Jen Gunter's book, she has a great chapter on brain fog. It is very common for women to feel brain fog as they are going through menopausal transition, and I am suffering that a lot. I've even spoken to my family physician about it because I was starting to forget names of people and names of medications that I should remember from medical school. And so my worry was, okay, is this part of menopausal transition? And as Jen points out in her book, very common, and it does not last. So brain fog is a short-term symptom in perimenopause and menopause. So you don't need to worry that it's going to be there for life. It's as our brains adjust to different hormone levels. Once they readjust to menopause, then the brain fog lifts. But my worry, like probably many other women, is, okay, I'm starting to have these small memory lapses for names. Is this the first sign of dementia? And so that is something that if there's a worry, like I did, check in with your family physician, get them to do some quick other questions with you to see, is there something worrisome there that you should go on and have more testing? They might want to know about your family history. Is there Alzheimer's in your family? And we know that women are more likely to suffer from Alzheimer's and dementia. So it might be something worth checking in with your family physician about with memory loss and brain fog. But as well, as we talked about before, you're going to notice a repeating theme is in keeping your sleep at its best will help with memory and brain fog. Eating a well-balanced diet, exercising, these are all things that can really help with that brain fog.
Yeah, that's great. There's been some questions too about it. We kind of touched on bloating, but I know as I'm getting older, like there's lots of commentary about how hard it is now to lose weight or how easy it is to gain weight. Is there any in between starting to go into perimenopause and issues with thyroid or your thyroid changing a bit? And are they linked? Yeah, a lot of smart people in this chat, I have to tell you.
We're smart as women. They've got a lot of good questions. And yes, so weight gain can be a symptom of low thyroid. And it is not unreasonable to have your thyroid checked if you're noticing some of these symptoms, and ruling that out, make sure that it's not your thyroid, because that is usually a very straightforward correction with thyroid hormone. Many of us are, I think, in the same boat with this perfect storm of perimenopause or menopause and a pandemic. And weight gain, we've seen weight gain for most of the population during the pandemic, and weight gain through menopausal transition is quite usual. And I'm not going to sugarcoat this. Not that I'm endorsing eating sugar, because that's not going to help. But the average woman gains between 5 and 10 pounds as she goes through menopausal transition. Personally, that is something I'm not interested in, gaining an extra 5 or 10 pounds. And it is harder to lose as you get older. So some things that I have found in the research on menopause to help counter that weight gain is looking back at your diet, again, eliminating processed foods, eliminating simple carbohydrates, reducing portion size. And that is hard to do, especially if you eat out a lot, because the portions that are provided to us are way more than we need. So it's maybe ordering off the appetizer menu instead of the main menu, which is sad because most of us love to eat. But reducing portion size, watching what you're eating. And then when you're focusing on exercise, focusing on weight-bearing exercises, that will build muscle mass. It's quite common for women to lose muscle mass as they go through menopause, but that can be countered by hitting the weights at the gym. You sometimes need to go into that back corner where the big guys are all buff with the free weights, and walk your way in there and start lifting weights, start challenging your muscles, start doing some those stretchy band exercises to help challenge your muscles, and that will help with weight maintenance through menopausal transition, and also keep your bones strong and healthy as you get into your older years. These aren't fancy treatments. It's what our grandmas always told us to do, right? Eat healthy and stay active.
Yeah, stay outside, and it's kind of the perfect storm too, because you're gaining weight, and maybe you have your hormones are going nuts, and you're like, you know what, I'm just going to sit with this ice cream and just enjoy it. But it's a really
so
good.
True.
I want to talk a little bit about, I'm going to clump these together, and maybe that's not the best, but a little bit about mood swings and anxiety, and some of, I guess, maybe the difference between addressing your body symptoms of menopause and when maybe you might want to consider seeking psychology help when it gets too extreme. I know there's a lot of kind of questions here around if my mom had a horrible time with particularly mood swings, and, am I likely to get that? Should I see my doctor early? So do you have any people that maybe are experiencing some anxiety, it's getting a bit worse, mood swings, all those things kind of adding up?
Yeah. And I think most of us women have had that experience of mood and its relationship to our hormones. If you remember back to when you were going through puberty, if you had some real struggles with mood at that stage in life, you may also be experiencing similar mood fluctuations as you're going through perimenopause. The other time in life that women may see hormonal effects on mood and anxiety is pregnancy. And depression and anxiety are common in pregnancy and common postpartum. So we know that for many women, hormones and mental health have a synergy and they work together. It's quite common to see things like PMS symptoms, like mood that is quite low leading up to the time of a period. Those symptoms can often get worse in perimenopause. Again, looking at a calendar might help understand whether this is more of a PMS hormonal kind of fluctuation. If you do see that pattern of every month, that there's that down spike in mood. Whereas if every day through a cycle, mood is low or anxiety is high, it may not be a hormonal issue and may be a primary mental health issue, which we would look at different kinds of treatments either way. I think if mental health issues like mood or anxiety are starting to change how you live your life, or you're finding it really hard to get through a day because of those, it's time to look for help. And that help might be through, again, your primary care provider, whether a nurse practitioner or a family physician. It could also be through a therapist. That might be someone you have a relationship with from before, or it could be someone through the workplace. And for example, as physicians, we have a group of mental health providers who are there to support us as part of our workplace. And many employers do have somewhere that you can go to discuss mental health issues. And similar to what Jody and I talked about earlier, with normalizing these conversations about mental health, I think are so important that we talk about these issues rather than women suffering in silence and just saying, we need help. And especially a time like this in a pandemic where people are living very differently than we used to. We don't have the supports that we did. It is understandable that we see more depression and anxiety, and I think the more we talk about it is better. And I think most of us reach out for help after we really needed to.
Yeah, I would agree. And hopefully conversations like this are making people feel more comfortable. And I do have a couple more questions. I'm hoping people can stay on and maybe can stay on for another 10 minutes just to get through a couple more, because we do have so many questions. But one of the questions, I guess, pertaining to that too, was for women that might be on medication for different concerns prior, like maybe ADHD or even anxiety prior. Is going into hormone therapy going to cause any issues for them? Anything that they should be concerned about in terms of other medication that they might?
Great question. And it's interesting, for one of the more common mood issues being depression, interestingly, in menopause transition, women who are on hormone therapy do see a synergistic effect with some of the antidepressant medications. So there can actually be improvement with adding hormone therapy for someone who is already being treated for something like depression. When it comes to some other medications for things like ADHD or maybe schizophrenia, that would be something to definitely touch base with your prescribing physician to see how would hormone therapy play into that. And I think that's a very individual decision, but it can actually, hormones can help with those symptoms as well.
That's great. Yeah. I wanted to talk a little bit. We did talk about hysterectomies and endometrial ablations. I want to talk a little bit about women that have PCOS or fibroids. Is this endometriosis? Is this something that they should be concerned about going into menopause or menopause? What kind of challenges might they have, if any?
So all three of those conditions, PCOS, so polycystic ovarian syndrome, fibroids, and endometriosis, these are all hormonally responsive conditions. So they can, all three of those get worse through perimenopause. But the good news is, and I even said this to a patient today who has PCOS, when she gets to menopause and her periods stop, she has graduated and she no longer has to deal with hormonal weird cycles and heavy bleeding and unpredictable bleeding. So menopause can be a breath of fresh air for women who suffer from hormonal issues. So for something like PCOS, where periods can be quite unpredictable and quite heavy, it's really important for those women to be seeking help if they're having issues. And women with PCOS are higher risk for cancer of the uterus. So that would be something that they should keep a close eye on, is what's going on with their bleeding pattern. Endometriosis, which is more commonly thought of as associated with pain. There are great treatments available for endometriosis. It has taken us decades to even have Health Canada approve medications for endometriosis, and we currently have 2 in Canada that work well for most women. In Calgary, we are also blessed with a team of endometriosis subspecialists within gynecology, and we have a number at each of the 4 hospitals in Calgary who are amazing at both the medical treatment for endometriosis as well as the surgical. So if you're a woman who is suffering with endometriosis, or suffering with pain, talk to your physician. If you are not getting solutions for your pain, ask for a referral to a gynecologist or to one of our endometriosis specialists. Fibroids are a whole talk on their own. Super common. About 1 in 3 women have fibroids. They can result in quite heavy bleeding or pressure symptoms because of how they're growing inside the pelvis. Fibroids tend to have most of their growth in perimenopause, and so that's often when we start to see problems with them. And again, we have a number of different treatment options to help with fibroids, and we're really just trying to get women to the finish line of menopause, to get them past that last period with fibroids, because once they're past menopause, the fibroids should not be causing them trouble beyond that.
That's great. Yeah, I think so many women I know suffer from that, and you're right. We could do a whole talk on that. Maybe we will actually. Have to start normalizing those conversations. I just want to ask 2 questions. We have to talk a little bit about it. Questions about vaginal atrophy, and so I think you mentioned it in hormone therapy, but can you talk a little bit about vaginal atrophy?
Absolutely. And it's interesting, even the term vaginal atrophy is what we were taught in medical school. And I remember hearing that term and going, that just sounds awful. And it's interesting, if you listen to Jen Gunter or you read her book, you do start to realize that the way we've named these things is horrible. We don't talk about penile atrophy, it's erectile dysfunction. And so we've got to find better names for these. And the current one for this is genitourinary syndrome of menopause. Basically, the tissue that lines the vagina and the lower urinary tract has estrogen receptors. And when your estrogen levels decrease over time, you can start to feel some discomfort in the vagina. It usually shows up about 6 or 7 years after your last period. So it doesn't happen right away for most women. And it could just be a general discomfort feeling, like, when you've got dry skin on your arm and it just feels sort of tight and uncomfortable. But it could also be that intercourse is suddenly quite uncomfortable because there's no lubrication that's coming along with having sex. So those symptoms are usually very easily treated. And the first thing a woman can do is go down to your local drugstore, to whether it's Shoppers or whatever drugstore you use. If you go to the condom section, and here's what drives me crazy. You go to that section and you'll see at the top are all the lubricants. In the middle is all the condoms. And then way at the bottom are all of the products for menopausal women. And really those should be at eye level. They can put the condoms way down low for young people who need condoms. But you have to go down to the bottom shelf and you'll see a selection of vaginal moisturizers. And moisturizers, just like you would think about using a moisturizer for your face, your skin, you could use that every day in the vagina. And that was like this little ovule that I showed earlier. So you could place that in the vagina once a day. It has no active medications. There's no hormones in this. It is a combination, and the different moisturizers have different components that will bring and hold moisture back in the vaginal tissue. The other thing to consider is the use of a lubricant for when you're having any penetration. So the lubricants that are on the market, there's a whole host of them. For a menopausal vagina, you would not want to go with anything that has got extra scents or tingly sensations. Those usually cause irritation for a menopausal vagina. You want to use something that is unscented, that's gentle. There's 3 different groups of lubricants that are out there. There's water-based lubricants, which are usually well tolerated, but they do tend to dry up a little bit after there's some friction. There's silicone-based, which are usually very comfortable. And then there's oil-based. And the best oil-based lubricants most women probably already have in their house, because it's coconut oil and olive oil. But as I tell patients, have a bottle for the kitchen and a bottle for the bedroom. You don't want to mix up your salad dressing with your lube.
That's very good advice.
Yeah. So lubricants for when you're having penetration, but moisturizers for the rest of the week. If that's not working, then see your family physician or gynecologist or nurse practitioner, because we can look at trying estrogen-based local therapy for that dry tissue.
That's great. I think you're going to have a bunch of women headed to the drugstore to reorganize the shelves here soon and put some things up where they need to be. The last question I just wanted to ask for the night, because we did talk about how prominent cardiovascular health concerns are for women and attention to them and our overall health. And I think when you and I were chatting, just to emphasize that journaling and things like that, going through some of these transitions is actually a really good time to do a check on your overall health. So I you mentioned that to me earlier, but I just wanted to ask about women with a history in their family of heart disease, or any previous heart concerns. What should they be thinking about that, as they enter into perimenopause, or maybe they're going through menopause, making sure that they really have a good pulse on their own health?
I like how you said a good pulse on their own health.
Intentional.
Yeah. I think it's a great chance to check in and, like you said, take your pulse. What is your blood pressure? Make sure that your blood pressure is in a healthy range. Family physician may also want to check on your risk for diabetes, because diabetes is a big contributor to heart health. They may also want to check to see what are your blood lipids, so that's your cholesterol levels, and to see, is that something that needs to be improved on. They also might want to take your weight or your waist circumference, and your waist circumference is a big indicator of heart health, because that measures what's called visceral fat. And so that's the fat that's on the inside of our bodies, not what you see on your hips. That fat that's on the inside of our bodies is linked with higher risk of heart disease. So if any of those are out of kilter, your family doctor might talk to you about ways to improve those factors, to improve your overall heart health. But I think most people know what those things are to improve. And it is, again, diet, exercise, stop smoking. Those are the biggest impacts you can have on your health, bigger than any medication. But for some women, they do need to look at going on medications to maybe manage your blood sugar levels. If you are in a diabetic range, women might need to check in on their blood pressure and maybe take some blood pressure lowering medications, and some women do go on medications to lower their cholesterol levels. One thing that I should mention is it's more and more recognized that for us as women, if we had a pregnancy, what happened in that pregnancy can have a big impact on our heart health. And something that has been recognized for the last decade is women who have suffered a condition called preeclampsia. And that's a condition where your blood pressure goes up in pregnancy and you can have some other changes to your kidneys and liver. Women who have preeclampsia in pregnancy are much higher risk of cardiovascular disease later in life. So if you remember having that condition during a pregnancy, it's really important that you stay on top of your heart health. And that would be something to definitely bring up with your family physician about something that happened to you in the past that would have a future implication.
Wow. Well, this has been such an informative conversation, and I just wanted to say thank you so much for having such a great and open dialogue with us. I think we have a lot of future topics that we could spend a lot of time talking about. There's still lots of questions, so hopefully we covered a lot of good information for people. So thank you for your time. I also wanted to say thank you for Lauren and Ramina, who have been answering some questions for us on the chat. Actually, Lauren is from the Libido Cardiovascular Institute here in Calgary.
Excellent.
And yeah, she's a little bit of an expert on hot flashes, which we didn't talk too much about, but I think we could spend a whole session on that as well. I just wanted to say to people, we are recording this session. You can access it. You can share it with your friends. You can share it with as many people as you like. You'll receive an email with the link, and it will be available on our YouTube. As well, we are looking for you to put your input into what we should talk about in the fall. So we covered some great things that we could have a whole talk on today, whether it's sexual health, whether it's fibroids. So we're going to send out a survey, and we really hope that people will participate and help inform future conversations just like this. So thank you so much, Dr. Matatal. And if people are looking to get more involved, they certainly can. And for that, I'm going to throw it over to my colleague, Mary.
My name is Mary Story, and I'm a development officer at Calgary Health Foundation. We hope you enjoyed this great discussion. As a foundation, we are committed to changing the status quo and making an impact in areas that matter to you. There are lots of ways you can stay involved, including showing your support by making a donation to support healthcare at calgaryhealthfoundation.ca or reaching out to any member of the Calgary Health Foundation team. Thank you.